Assalamu alaikum. Good afternoon, everyone. I am Moustafa AlDaly, Assistant Professor of Clinical Oncology at AlAiny University Hospital. First of all, thank you for the kind invitation. And today we are going to present our Namrock Gynecology Brachytherapy unit with our 4 years HDR experience. Next. This is our department. It's an old department, maybe one of the oldest clinical oncology departments in Egypt. And in this department, we have recruited brachytherapy service maybe 40 years ago, including radium needles for head and neck indications, radium for brachytherapy gyna. We joined also the era of low-dose rate brachytherapy using cesium. And lastly, 4 years ago, we started to implement HDR cobalt-60 brachytherapy service. We have treated near 1,000 patients with 200 cases of CE cervix full application. With or without needles, nearly 40, including different interstitial needles, template, and also tulip applicator. I will show you this in the next slides. Next. Brachytherapy service actually is an old technique. More than 100 years ago, brachytherapy started with Professor Marie Curie invention of radioactive sources. And since that time, calculation systems were also implemented, including Manchester system in 1930s. Then in the 70s, we witnessed the era of low-dose rate brachy with the use of cesium, and lastly, HDR brachy with the use of iridium first, then cobalt has changed the face of modern brachytherapy, including also implementation of image-guided 3D and MRI-based brachy. So it is an old historical technique with a very old but CE cervix. Next, please. What makes CE cervix different and more amenable for brachytherapy is actually different components. First, it is a radio-sensitive disease. Squamous cell carcinoma of the cervix is one of the most sensitive tumors that lies within an envelope of radio-resistant organs, the uterus, the cervix itself, and the vagina, and surrounded by more or less radio-tolerant organs as the rectum and the bladder. Gyna indications are much more easier and accessible when compared to other brachy indications. It is not a blind technique. And all these factors help in the early introduction and early success using brachytherapy in the treatment of gyna indications. Next. This is our unit. We have multi-channel. We have 25 channel afterloader coming from Eggert and Ziegler using radioactive cobalt source with 3.5 of radioactivity. We have a unique design allowing our operation theater and bunker to be immediately in front of CT, this to control the time, which is a real important factor in the management of brachytherapy. And we also recently recruited an ultrasound with abdominal, hopefully with coming vaginal probe for proper assessment of intrauterine tandem position, as well as helping the positioning of interstitial needles. Next. And the day of brachytherapy is really a busy day with a lot of tasks that should be performed in a tight and time-controlled way. We start with daily quality checks, assessment of the patient for anesthesia with the anesthesiologist, examination under anesthesia with assessment of extension of the disease, doing your insertion, dilatation, inserting your tandem, sending your patient towards CT, doing your job as a radiation oncologist with contouring, then planning, plan acceptance, treatment delivery, and removing the applicator and following the patient till recovery. And all this should be performed for 3 times. As we can see next, in our department, we utilize the protocol of 8 gray multiplied by 3. Other departments, of course, can use more fractions, but with a very busy department and very high load of patients, we decided to take this fractionation regimen at the time being. We have also research with the use of 7 multiplied by consecutive weeks, and the data are going to be published recently. Next. I would advise any starting department, either with or without the service of brachytherapy, to utilize the diagrams of Kasr. This will improve the common language between doctors working in brachy units, and also helping the referral process of patients among different departments. Examination can be performed at the time of external beam and at the time of brachy, using color codes for definition of tumor extensions. The cervix, as we can see the colors, the cervix in red, the vagina in green, the parametrium in blue, and you do your drawings in the coronal, sagittal, and axial. All margins of the cervix can be assessed clinically, except the retrocervical margin that requires MRI or ultrasound imaging. And particularly for the vaginal or extension, clinical examination may be the best for assessment of extent of the disease. So if you don't have brachy and you want to be aware and oriented and trained in gyna examination from radiation point of view, kindly implement the use of these diagrams. Next. تمام اللي بعدها our applicators. In our department, we have, of course, the most famous, the most frequent type of cases of vaginal vault after endometrial or cervical cancer management with surgery with certain indications. We use our Miami applicator, a type of vaginal cylinder that is multi-channel, allowing the delivery of the dose in a differential way, maybe for different thickness, maybe with the dog ear vaginal vault. It can help in shaping of the isodose line, and Miami applicator also allow the use of intrauterine tandem. Usually we use the intrauterine component of Miami for the treatment of cervical stump or vaginal vault recurrence with the multi-channel insertion to improve the dose, as well as for the classic vaginal vault irradiation. Next. As we can see here, the classic vaginal cylinder versus the multi-channel applicator, and we can see this mushroom-shaped isodose line or the differential dose on the right versus the left for patients with a different topography or for localized vaginal vault recurrence. اللي بعدها يا فندم. What about full application? Actually, we are really lucky to have a lot of weapons in the treatment of full application, starting from the classic flexure, the ring with dual dime adjustment with the rectal retractor. We have also the perineal, the gynecologic, the template, the MAC applicator that help in the treatment of cases with lower vaginal extension and treatment of parametrial as well as lateral pelvic disease. And we have performed a matter of 5 to 6 cases of local advanced cervix using this applicator, but it is really injurious applicator and needs assessment with your radiologist, as well as better to have a surgical backup. Next. This is the classic flexure. We use the flexure for large size tumor, or when the vagina doesn't allow the introduction of the classic ring. What is unique regarding the flexure applicator is the capability to adjust the length of the intrauterine tandem for large size uterus, as well as the variation in the angles help you to treat forms of retroverted uterus, for example, and different more variation of uterine anatomy. It's not common to use all these angles, and usually I utilize flexure for retroverted uterus, or where the ring cannot be introduced due to lower vaginal stenosis. For African circumcision, for example, we can face this situation. Next. The classic ring with or without the needles. The needle help into boosting the dose to the parametrium. We do have the Vienna applicator. However, Vienna is not that easy to introduce the needles due to technical aspect in the applicator itself. We can see the shape. نقدر نشوف الصورة of the change of isodose line. Next, بعد إذنك. And how can the needle push the high dose region towards the parametrium and improve the treatment delivery? Of course, Vienna data emphasize on the use of interstitial brachytherapy to improve the delivery of high dose toward the tumor extension. Next, please. This is the most recent applicator at our unit. We have used it for around 5 cases. It is a 2-lead applicator with it's a form of advanced Vienna, maybe Vienna 2, with chances for inserting needles, oblique needles anteriorly on both sides and posteriorly, as well as 2 lateral needles centrally, and component of needles around the intrauterine itself, improving the dose for case scenarios as anteverted uterus. This applicator is much more easier to use. Needles are easily introduced and controlled by a form of a ruler designed for this, and with the use of ultrasound guidance, I think TULEAD is really a form of successful applicator in patients with need for interstitial brachytherapy needles. And Dr. Radwa, my dear colleague, will show you some of our cases using interstitial needles in different case scenarios. Next, please. Lastly, MEC. A MEC applicator allow you for the use of much more number of needles. It is suitable for patients with lower vaginal extension, or where the dilatation of the cervical canal or the introduction of intrauterine tandem is not that easy. For a barrel-shaped cervix, interstitial interstitial needles can be introduced around the vaginal cylinder, to the parametrium, to the lateral pelvic wall. There are some holes also for the treatment of parametrial extension immediately behind the bladder or anterior to the rectum. But choosing to use this applicator requires ultrasound guidance as a mandatory part in order to avoid bladder injury, and BR examination during the insertion of the posterior needles to avoid erectile injury. Next. Okay, we currently in the era of image-guided brachytherapy, and this is actually an old debate. We are currently in the era of MRI, but I will rapidly revise the progression from 2D toward 3D. اللي بعدها يا فندم. We know that brachytherapy is an old technique started, as I have mentioned, more than 100 years ago, with the use of films. Was introduced initially for the dose distribution, depending mainly on the applicator. And with the use of this technique, we have a good outcome. However, we don't know the real extension of the disease, and we don't know where the bladder and the rectum exactly. This technique depends mainly on point dose calculation rather than real anatomical organ definition. Next. And when comparing CT-based versus 2D film-based, actually the iSDose lines are really under-treating those patients, particularly for patients with high-volume tumors in the cervix. Only 40% of the tumors were covered using this approach. And it is as when we compare 2D to 3D, non-individualized form of those prescription. Next. For the organs at rest, using point dose calculation rather than volumetric data will actually not reflect the real high dose within the bladder that is much more higher than we thought from the previous bladder point, opposite to the bladder dome. Rectal point may be representative of the high dose region, but it is not that accurate. And also the calculation for the dose for the sigmoid and the bladder is lacking with the use of 2D imaging. Next. So we are in the era of 3D based. CT actually is not enough, maybe enough for the identification of the bladder and the rectum, but CT does not identify the GTV within the cervix, does not give us information regarding parametrial extension. The uterocervical junction actually cannot be easily identified using CT. And CT usually overestimate the size of the cervix compared to the MRI, as we can see in this images. MRI image T2 weighted without the contrast carries a high accuracy for definition of both cervical and extracervical disease, reaching up to 90%. And with the overestimation of the cervical volume using CT, usually we contour larger volumes that may impact the bladder and the rectum at a higher doses. Next. Do we have any available literature regarding the use of CT? The reason why I'm talking about CT that we unfortunately don't have MRI at our department, and we are trying to justify our job as much as possible. One of those trials, the STIC trial that included 800 patients, showed how much the CT-based brachy was more or less superior with the use of 2D images from a local regional control point of view and from a toxicity point of view also. And this is our current standard. We use ultrasound to improve our identification of the tumor, but we don't have MRI at our department. However, next. We are in the era of MRI-based brachy with the identification of the tumor, of the cervix, and the initial size with the use of a GIC recommendation regarding contouring for the GTV, for the high-risk CTV, including the cervix proper, and for the intermediate risk CTV, including the initial cervical size with a subtraction from the nearby bladder and rectum. And the MRI is performed in T2 weighted series on each fraction with fusion, allowing better dose calculation and maximum avoidance from the nearby organs at risk. Next. ICRU report describe the GIC guidelines in details from different aspects, radiobiology, physics, and clinical case scenarios. Up to 8 cases are included in this report with different drawing defining the extent of the disease. Next. I advise any colleague that is really interested in HDR of brachy to go this valuable piece of information, a large piece actually of a lot of details of information in HDR brachy. As we can see here, one of the scenarios for tumor extent where the GTV is contoured in blue, surrounded by the cervix proper in red, and the yellow color reflects the intermediate risk CTV. Those prescription, of course, is for the HR CTV, and in CT based, you don't see the GTV, so you don't actually contour this blue line. Next. What about plan acceptance? Those specification in 3D brachytherapy come from the literature of MRI based, of the recent MRI based from Vienna School of Brachytherapy, and data coming from Embrace trials. We know that we should exceed 90 gray, and the concept of D in 90 is correlated with the local regional control and treatment outcome. Of course, the absolute dose depend on how much dose per fraction you give for in your center. So D90 exceeding 87 gray or higher is preferable, and this is an important point for plan acceptance. Optimizing your plan with the use of interstitial brachytherapy is now considered an important component to reach this high level of coverage. Regarding organs at risk, the definition of doses to the organ at risk depends on the T2cc concept, and D2cc concept for the rectum and the bladder to cover a cumulative dose, not to exceed a cumulative dose of 75 gray for the bladder, 70 gray for the rectum, in order to limit your toxicity around 5%. But actually, in real case scenario, we may reach to higher levels, especially with the large size tumor. But to respect that increasing the dose will be reflected into increase in the incidence of toxicity. Avoid the sigmoid, avoid the bowel as much as possible, and actually you will reach the sigmoid or the small bowel in scenarios where you are using a high intrauterine tandem for large-sized uterus. Take care not to deliver any hotspots to these organs. Next. And here is one of our cases with the intrauterine ring rectal retractor, and we can see the nice dose distribution and follow the dose away from the bladder and the rectum. Next, and we can see the DVH that is characteristic for brachytherapy, the heterogeneity of the dose, and the D90 concept, and how much you can see how much higher dose than what was prescribed delivered to the center of the cervix, related to the nature of HDR or brachytherapy in general, and the rapid fall of the dose. So actually the cervix is treated by much more higher than the 8 grays or whatever dose you prescribed for the patient. The dose, the 8 gray, for example, in our case scenario, is delivered at the periphery of the volume, where the center of the volume can be treated to doses up to 20 grays. Next. So this will be the last slide. The next slide, my dear colleague, Dr. Radwa Handi, she's going to present live case scenarios using the applicator that I have shown in previous slides. And we can, of course, accept any questions either now or at the end of Dr. Radwa Handi presentation. This is the end. Thank you so much for your time. Thank you.